My patient is a 25-year-old student who has to leave her BSc final exam and was brought to the general medicine OPD with the chief complaints of excessive coughing since past 4 months, generalized weakness since past 1 month, vomiting just after eating and diarrhea since past 7 days, and seizures at presentation. Next slide, ma'am. So she has a history of chronic productive cough with whitish sputum on and off since past 5 years, and which got exaggerated since 4 months. So this is suggestive of lower respiratory tract infection. Then she has a history of generalized weakness and fatigue, which was more since past 1 month, and although it was present since past 2 years. So this is suggestive of hematological disorders, infections, and endocrine disorders. Now she has also the history of non-projectile, non-bilious vomiting just after eating, and watery, greasy, and foul-smelling stools after having food from a canteen nearby her hostel. So this is suggestive of gastroenteritis. The patient had generalized tonic-clonic seizure on presentation, but there was no such history of any seizure in the past. So, in the past history, she has a history of recurrent infection and fever since her childhood, which got resolved after getting antibiotics, and it used to occur every 2 to 3 months. So, that is suggestive of immunodeficiency. The patient also had difficulty in hearing since past 2 years. The patient was born after a normal vaginal delivery, but she was admitted in hospital because of pleural effusion for 15 days, but there is no history of any joint pain, dryness, or allergy. So this history of hearing loss is generally seen when you have some sort of immunodeficiency just after your birth or since birth, and the history of joint pain and dryness generally comes later on, whereas allergy can be present in both the cases. So she is born in a Hindu family of a non-consanguineous marriage of her parents. She has mixed diet and there is no addiction, and her sleep is normal. The bowel and bladder on presentation, she had 4 to 6 loose stools per day, and there is no change in urination. And her vaccination status is complete. It was essential to ask about the vaccination status because there is less flaring in immunodeficiency during vaccination. Ma'am, next slide. So her family history is not significant except the death of a paternal aunt just after the birth due to infection. So the treatment history reveals that she has got antibiotics from some private clinic and she was not having any record of it, and the names of the drugs were not recalled by the attenders. Next slide, ma'am. On general examination, the patient was oriented for time, place, and person, but she had low BMI, 17.8, and she was tachypneic and tachycardic and pallor on present. And there was no history of icterus, clubbing, cyanosis, edema, or lymphadenopathy. But the CVS revealed increased JVP, and S1 and S2 was present. There was ejection systolic murmur present in an abnormal area, mitral area, carotid root. The respiratory system revealed bilateral crepitations present in interscapular and infrascapular region. Her abdomen was soft and non-tender, but it revealed drop space dullness, which shows splenomegaly, and liver was palpable 3 centimeter below the right costal margin, which shows she has hepatomegaly as well. So the differential diagnosis out of the presentation of recurrent episodes of infection was suggestive of some immunodeficiency, which is now termed as inborn errors of immunity for primary immunodeficiencies, and she has got a genetic testing done which revealed common variable immunodeficiency was present. In the present scenario, when she has presented so acutely, it was essential for the doctors to differentiate from the following DDs, like whether she was having tubercular meningitis or some fungal infection, maybe aspergillosis or cryptococcal infection, autoimmune encephalitis, which is chiefly NMDA encephalitis in case of young females. Next slide, ma'am. So on investigation, she was found to have low hemoglobin, 6 gram per DL, for which she was given 2 packs of RBCs. There was leukocytosis, and the differential leukocyte count revealed more of lymphocytes. Platelets were high, total bilirubin and direct bilirubin were normal. Protein was normal, but what was peculiar about the status was albumin was within the normal range, but globulin was always below the normal range, which was 2 to 3.2. So this patient always had 0.8 to 1.7 globulin level. AST, ALT, and ALP were normal on presentation, but on her second presentation, the first presentation was on 22/7, and the second presentation was on 9th of September. So on the second presentation, her AST and ALT were 3 to 5 times the baseline. The KFT was normal. Serum iron was found to be low. TIBC was low, ferritin was high, and CSF ADA was markedly high, that is 25, and the normal level is 0 to 9 international units per liter. Her thyroid function test was normal, prolactin was normal, but all the immunoglobulins were markedly reduced. Ma'am, next slide. Her vitamin B12 level, cortisol level were normal. Coming to microbiology, so her occult blood test was negative, but the routine RM of stool revealed Giardia intestinalis, which was the cause of gastroenteritis. Her CSF CB-NAT ultra was negative. Serum galactomannan was negative. So that has ruled out the fungal infection. Her NK cell activity was reduced, but CD4 CD8 count was normal. On blood grouping, it was interesting to find her with O positive blood group, but she was not producing any anti-A and B antibodies. So that was again suggestive of immunodeficiency. Ma'am, next slide. So her genetic testing revealed LRBA gene deficiency, which is located on exon 4, and there was a variation in the cDNA at 6437 position. The thymine was being altered by cytosine, and the protein methionine at 2146 position was being altered by threonine, and it was a compound heterozygous mutation. So the mutation was of uncertain significance, but the disease came out to be common variable immunodeficiency. Ma'am, if you click, yeah, so this is the whole an autoimmune encephalitis panel which was done, and it was negative. And her ANCA was also done, which was negative. So on radiological investigation, the right lobe X-ray revealed the right lobe consolidation with symptomatic effusion, and HRCT showed bronchiectatic changes in the right lobe. Ma'am, next slide. So coming to the table, the differential diagnosis for tubercular meningitis, fungal infection, or NMDA encephalitis will be dealing this table from the bottom. So EEG was performed, which was normal. So that has ruled out NMDA. Galactomannan was serum galactomannan was performed as the BAL sample was less. So this has ruled out the fungal infection, but still there was confusion between fungal and tubercular meningitis. So lymphocytic pleocytosis was seen in CSF examination, and the level was around 250 to 300, which is more suggestive of tubercular meningitis. Higher levels are also found in fungal infections, but it is yes or no. But if you see the ADA level, there was marked raise that is peculiar of tubercular meningitis, and that is not so much raised in the fungal infection. So this patient, the clinician has treated this patient with the diagnosis of CVID and tubercular meningitis with ADT, and she had shown marked improvement after the treatment. So after this treatment, she visited the hospital back again after 2 weeks with the complaint of vomiting, and then when the LFT was performed, the AST and ALT levels were found to be 3 to 5 times higher than the baseline, and her bilirubin was mildly raised. So she was denoted as drug-induced, suffering from drug-induced liver injury, for which modified ATT was given. So coming to the discussion, what is common common variable immunodeficiency? It is a disorder characterized by defective B cell function, leading to the impaired immunoglobulin production, and it can present with heterogeneous clinical manifestations like recurrent infection, chronic lung disease, autoimmune disorder, gastrointestinal disease. The prevalence is around 1 is to 25,000 in Europe. In India, it is 1 is to 50,000 to 1 is to 1 lakh. And the prevalence is increasing as we are developing in diagnostics. The age generally affected or found to be affected is 20 to 45 years, and there's no gender predilection. The pathophysiology of the disease circumvents around the B cell maturation and function defect, but it can include T cells as well. Ma'am, next slide. So the scientists Chappell et al. Have classified the clinical manifestation of the disease into 5 categories, which include uncomplicated, means the patient is just presenting with recurrent infections, or autoimmunity, polyclonal lymphocyte infiltration, enteropathy, or lymphoid malignancy. So, in our case, in infections such as tuberculosis, immunodeficiency leads to a faster progression of the active tuberculosis, along with more chances of disseminated tuberculosis. These tubercular meningitis, they're basically found by granulomas. And what are granulomas? Granulomas are localized collection of central accumulation of macrophages with a surrounding rim consisting of lymphocyte and fibroblast. The pathophysiology of formation of granuloma in patients with IAI is unclear. The prevalence of granulomas in IAI is reported to be 1 to 4%, with the highest prevalence in CVID and chronic granulomatous disease. Later, this patient was just treated on IVIG, and now she is doing fine. So these are my references. So coming to the questions which can be discussed, like what are the biochemical methods used for the evaluation of ADA and CSF? We can evaluate ADA and CSF by using calorimetric method, in which there is conversion of adenosine to inosine, and the ammonia produced is reacted with phenol, which leads to blue colored compound. Spectrophotometric method can also be used, and ELISA can also be used. So, in the genetic report, we have seen the analysis was done using NGS, in which only one mutation was found, only one allele affection is found, and it is LRBA deficiency is actually biallelic mutation, and it is autosomal recessive. The case was a compound heterozygous case. So, if we do MLP in such conditions, we would be able to find out what is the another mutation, and can and whether that mutation is significant or not. For that, we need to investigate the parents also, but since all these tests are expensive, so they have not gone further beyond it, and the patient has recovered markedly. So the take-home message is early detection of IEIs. Like if she would have been detected with her albumin level or her blood grouping, she would have been treated much earlier, because she was presenting with some coughs and recurrent chest infections readily from her birth. So if you could detect IEIs and can think of IEIs much earlier, the patient would not have landed into seizures and tubercular meningitis. And this particular group of disease, inborn errors of immunity, make people susceptible for autoimmune and autoinflammatory diseases and cancers. 10 to 20 times more susceptibility is there. So if you could detect all these diseases much prior with our diagnostic test, so it will help in lessening the burden of the disease in the society. So we should focus more on development of diagnostics. So my acknowledgement include Department of Biochemistry, Department of General Medicine, and the family members of the patient. At last, I want to thank my institute. Yes.